All right, welcome everyone to week 11. Hopefully you're all holding on. Just 2 more weeks left and you'll be all good. So today we're going to, oh, why is my, okay, there we go, it works. Today we're going to do some cardiac phys as well as a little bit of blood vessel histology. It's literally 2 slides, so it's very minor. But then we'll also be doing clin skills. Definitely try and stick around for clin skills. I know it doesn't sound as fun and doesn't sound as high yield, but it really is. A lot of your exam will be on clin skills, so make sure you pay attention to that. Just before we keep going into new content, there were some questions that I wanted to do with everyone here from 2 weeks ago. So we'll have a go, all right? I know these questions I made, they're purposely quite difficult questions, all right? So I think they are worth doing, even if you guys just want to have a guess. So during a heart transplant, the vagi nerves were cut. What would you expect the resting heart rate to be? Just put something in the chat, or you can message me personally. I really don't mind. Let's have a go. To be honest, the first time I came across this, I just completely guessed. I was like, oh, yes, very well done. It is D, correct. So the reason for why it's D is because the vagus nerves were cut. So vagus is parasympathetic, all right? So you've lost all your parasympathetic innervation to the heart. Now remember that the heart has vagal or parasympathetic resting tone. Okay, so it's usually a lot slower because the parasympathetic nervous system slows it down. But without that, we go back to the intrinsic rate of the sinoatrial node, which is about 100 beats per minute. That was really good. Well done, guys. You're doing better than I was last year. Continued question 1. So during a transplant, a heart transplant, the vagal nerves are cut. Could this patient's heart rate be increased, decreased, or unchanged? Be careful, think about this one. Anyone have any guesses? This one's a bit of a tricky one, but very well may come up on the exam. Okay, so almost. So this one is increased. This one is a really hard one, so don't blame anyone at all for not getting this one. It is a really tricky one. So in this scenario, because the vagi nerves were cut, we don't have any parasympathetic nervous system. However, we still have a little bit of sympathetic nervous system happening because you still have hormones circulating in your circulation system, so they're still going to act on the heart. Okay, because if you remember, your parasympathetic nerves, they synapse very close to the end organ, so that's why your parasympathetics aren't working, but your sympathetic is still intact. So if you remember, your sympathetic nervous system can increase the heart rate, all right? So that's why we can increase the heart rate, because you still have your sympathetic nerves intact. You can't decrease it because you don't have any parasympathetic innervation to the heart, it's all gone, and parasympathetic decreases the heart rate. That's why you can't really have anything there. That was a hard one though, but again, these are the types of questions that could very well come up in the exam because they are quite tricky. So it's good that you're seeing them now. I think this is the last question. So the SA node has failed to work. What is the expected heart rate now? Okay, good. Yeah, everyone got that correct. Very nice. It's 50. So this is because when the SA node fails, we have the AV node starting to work instead because it's the fastest node and its intrinsic rate is around 50. All right. There's always a little bit of a range, but just remember 50 and you should be good. And yeah, if it was the Purkinje fibers, can anyone tell me what heart rate would be? Yes, it'd be A, which is 30. Yep, good, you got that. That's really good that you've understood this because, yeah, you're on your way. Okay, so next slide. Oh, last slide. A patient has come in with an AV block. What is his heart rate? This will come back a little bit in ECGs, which we'll be covering next week. So keep in mind AV block. AV block is just when there's no communication between the AV node and the SA node. Just have a think about that. This one's also a tricky one. Take a guess. Okay, so it is A. So this one was, again, a really hard one. So I get where people are saying maybe D at 100. Okay, I understand the logic there. So AV block, again, as I said, there's no signal traveling between the SA node and the AV node. Okay, but both are still firing. All right, so the SA node is going at its rate. All right, and the AV node is going at its own rate. All right, so the AV node is firing at around 70 to 100. Okay, and the PSPupper goes at 15 to 40. However, the heart rate is set by the ventricles contracting. All right, so the ventricles are contracting at around 15 to 40. Sorry, I think I said AV node earlier. I meant, so AV node does not transmit the signal. So the SA node is working, the Purkinje fibers are working. Okay, your AV node isn't really doing anything. So your ventricles are actually contracting at 15 to 40. And remember, your heart rate is not set by whatever node is going fastest. It is set by your ventricles, whatever rate your ventricles are going. So in this case, the ventricles are going at 15 to 40, so your heart rate will be in between that, so 30 in that case. That sort of makes sense, and this is, sorry, I kind of screwed up. So AV node doesn't work here. So it's just SA and Purkinje that you're sort of paying attention to. All right, so we'll keep going. Have another look over these questions. If you just go over in your own time and listen how these work, I'm sure if they come up on the exam, you'll know what the correct answer is, because these are quite important to know, and I would guess they come up on the exam. So we'll keep going. So today I'm going to talk a little bit about the circulation. So first we're just going to talk about the blood volume throughout the body. So there's really two main parts to your general circulation. You have the systemic circulation, and you also have the pulmonary circulation. So the systemic is just the ones that's going through all your tissues, all your organs, and your pulmonary is the ones that is found in the heart and the lungs, okay, more so the lungs. So most of your blood is actually in the systemic circulation, as you can probably guess, with about 16% in your pulmonary circulation. What is important to note, you don't have to remember any of these percentages, they don't really matter, you're definitely not going to be asked that. It's just to highlight how much blood is actually in the systemic versus the pulmonary circulation. It is really important to know, however, that most of your blood is in the veins. Okay, you could be asked that. Yeah, it's very important. And this is actually because the veins, as you hopefully might have picked up, the veins are actually thinner than the arteries. And because of that, they're less rigid than the arteries and more compliant. So they can actually hold more blood. They can accommodate more blood than the arteries. Right? That's basically why there's so much in the veins. From that slide. So this is just a slide giving a bit of a definition as to all the different parts of the circulation. So again, arteries are the ones that are transporting blood away from the heart. They're very high pressure. You do have to know that. They have very strong vascular walls and a really high blood flow rate because of the high pressure. Right? Arterioles are the kind of smaller versions of arteries, okay? However, the main difference between arteries and arterioles, apart from being smaller, is that arterioles can actually open and close, all right? So they can actually shut off blood flow and then open up. Whereas arteries, they're always open. They don't have anything that will shut off blood flow through them. Whereas arterioles, they can open and shut. All right? And we'll be talking a bit about that a little bit later. That comes into autoregulation. We'll discuss that. But basically, arterioles are the whole point. So arteries are the ones transporting the blood. Arterioles, they're controlling the blood flow through tissues. So they can shut on and off depending on how much they think the tissue needs, how much blood the tissue needs. Then we have capillaries, which is where the arterioles and venules meet to exchange fluid. And what is really important to know is that they're very porous, and that's because they need to exchange nutrients, oxygen, waste products. So you can expect that to be very porous for that exchange to happen. Then we have venules, which is basically, again, just small veins. Don't really have to know too much about venules. And veins are the ones that are going back to the heart. And as I said before, most of the blood is in the veins. So it's considered a reservoir of blood. So what I mean by reservoir of blood is just where the blood is sort of found in your body most of the time, which is in your veins. Another reservoir, which is just for fun, is your spleen, for example. There's a lot of blood building up there. But yeah, veins are a reservoir of blood. Also, I'll just add, almost most veins have valves. There will be some that you'll encounter mainly in second year that won't have valves, like in your abdomen, some thorax and some head veins, whilst arteries are always valveless. They never have valves. That is really important to know. Yeah, that's all I said there. Okay, blood flow. So in cardiac phys, you'll come across, maybe you've already seen this, but you'll come across a few equations. And I recommend, if you're pressed for time, okay, and you're struggling, because I remember last year finding it really overwhelming, having to do all of this cardiac stuff with 2 weeks until the exam. It was very stressful. If you feel you are pressed for time, number one most important thing to know are all the equations. There will be a summary slide at the end of this presentation with all the list of equations. If you're really pressed for time, just memorize that and you should be good for the majority of questions. Now, of course, that's not ideal. You'd like to be understanding everything behind the equations, but if you are pressed for time, definitely do the equations, really important. So blood flow, as you can probably infer, that's just the flow throughout the vessels. It's dependent on 2 different things. It's dependent on the change in pressure between 2 ends of the vessel, as well as vascular resistance. So there's your equation there. So you can imagine that if the start of the vessel, okay, is really super duper high pressure, such for example in your arteries, and the end is super low pressure, for example your veins, the blood is flowing quite fast because it's being pushed by your arteries into your veins from a high pressure to a low pressure. All right. So the greater difference there is in pressure, the more blood flow you will have. Now, vascular resistance is basically what the blood has to overcome in order to flow. So you can imagine if there's more resistance, there is less flow. Okay, it has to work harder to overcome any barriers. Okay. This equation is important. It is only for laminar flow. So laminar flow, I know it sounds like a very fancy term, and I didn't do physics, so don't worry, you still can understand things. I just have here, you can see these are just blood vessels, all right? So A is an example of laminar flow, all right? And B is turbulent. You can see all the fluid, the blue line is supposed to be fluid. They're bumping into all the walls. It's not very smooth, whereas laminar, yeah, it's just going straight through the vessel without turbulence. This equation is only good for laminar flow. So that is kind of important to know. And most of your vessels should be as close as possible to laminar flow. However, they won't be at laminar flow if they have atherosclerosis. Okay, so if you have atherosclerosis, which is plaque buildup in your vessels, you'll have turbulence, and this doesn't start to work as well in people with atherosclerosis. That is important to know. So the overall blood flow of the total circulation is about 5 litres per minute. So it's actually quite a lot. And that's also the cardiac output, which we'll talk about in a second. So now we're going to touch on autoregulation. So I touched on this before. So basically autoregulation is basically when you have a certain amount of blood flow, okay? And even though you have an increase in blood pressure, say you have hypertension, your blood flow, the rate at which it flows, it won't actually change that much. And that is primarily because of the arterioles. Okay, so if we go back to our previous slide, oh gosh, sorry, here we go. I did talk about how they kind of control blood flow to the tissues. So if there's too much blood pressure going, there won't be a lot of blood flow because the arterioles can actually constrict and they won't let as much blood in. And that makes sense because you don't want to flood all your tissues with too much blood under too high of a pressure, because there just won't be enough time for all the diffusion to happen that's necessary for those tissues. So there won't be enough time for oxygen to be transported or waste or nutrients. That's really important. We'll touch on autoregulation a little bit again later. It will make sense a bit later as well. Yep, so now we'll just talk about resistance. So resistance is basically the forces trying to block the flow. We talked about vascular resistance earlier. And you can see from this equation that the resistance is the inverse to the radius to the 4. This basically means that the bigger the radius, the smaller the resistance. I guess it makes sense if a vessel is really big, you have more space for blood to actually flow through, right? So you can kind of think about it like that. Now, really important to note here that since radius is to the power of 4, even a tiny change in radius is actually a huge change in resistance, right? And that's really important. There are other factors that can affect resistance, such as viscosity and vessel length. Vessel length we're not really interested in that, since you can't really change the length of your arteries or veins. But viscosity has a bit more importance because you can actually change the viscosity of your blood. So you might even heard of blood thinners, for example, that can be given to patients, and that already changed the viscosity of your blood. But it's not that important for this year level. But yeah, just do remember this. I think there was a question last year on this exam. I can't remember, but really important. Compliance. So compliance is basically how easily a vessel expands when filled with a liquid. You can kind of think of it like an elastic balloon, and how elastic balloon, I don't know, is more compliant than a piece of paper, right? When we're comparing the materials. So compliance is dependent on the change in volume and the change in pressure. So if the vessel is able to easily accommodate a greater change in volume, it means that it's more compliant. So you can think about how an elastic balloon easily goes from holding a little bit of air to a whole ton of air. So it's very compliant, as opposed to if you're trying to blow up a balloon made of paper, you can imagine that you're not putting a lot of volume in it, so it's not going to be very compliant. Compliance is also inverse to the change in pressure. All right, so you just have to think about that. What is really important to know is that compliance is actually a lot bigger in the veins as compared to the arteries. And again, that's because veins are a lot thinner. All right, and if you remember, your veins are a minor reservoir of blood, so they hold a lot of blood, and it's because they're more compliant. That's why it's important. Pulse pressure. So pulse pressure is basically just your systolic minus your diastolic pressure. Okay, so if you were to take a normal blood pressure of 120 on 80, 120 minus 80 is 40. That's your pulse pressure. And basically that represents the force that the heart generates each time it contracts. Okay, so if you have normal blood pressure of 120 on 80, pulse pressure is approximately 40 milligrams of mercury. And that's the force your heart generates each time it contracts. You can imagine that if there is a greater systolic volume, okay, so remember from our presentation 2 weeks ago, that basically means more blood is being pumped out. There's going to be a greater pulse pressure, right? And compliance is also really important in pulse pressure. Basically, the less compliant your arteries and veins are, the greater rise in pressure for blood to be pumped into arteries. So you just have to overcome more resistance to actually get the blood flowing. Yeah, so all you have to know is just systolic minus diastolic, and again, you very well could be asked. You probably won't be asked anything about stroke volume compliance. You'll more likely just be asked what is the pulse pressure in this patient. Mean arterial pressure. So this again kind of going back to our presentation last time, but mean arterial pressure is the average atrial pressure over a period of time. All right. So the formula here is 1/3 of your systolic plus 2/3 of your diastolic. Okay. Now this is important. Listen to this. So your mean arterial pressure is normally always going to be closer to the diastolic. So the diastolic is the bottom number. So if we're 120 on 80, your mean arterial pressure is always going to be close to 80, then to 120. And that's because 2/3 of the cardiac cycle is spent in diastole, because most of your time is spent filling up with blood and then being ejected. Okay, so 2/3 of the time your heart is in diastole, it's filling with blood, and then 1/3 of the time it's ejecting and it's contracting. Right. So if you can think about, if you're wanting to find the average pressure, that's why you have 1/3 of systole and 2/3 diastole. And that's basically because we take 2/3 of our time in diastole. So this is important, and there might be a question coming up on this. Pay attention. Yeah. So this is actually a little bit of a tricky one. Okay, it's an application question. Again, very well could be asked on the exam. At high heart rates, what does the mean arterial pressure approach? I will suggest you have a think about what is happening to systole and diastole in a high heart rate. Have a guess. This is a hard one. Okay, so this one was a really tricky one. So in a normal high heart rate, in a normal heart rate, say 70, okay, your mean arterial pressure will be the difference between systolic and diastolic. So you're right if it's normal, okay, but in this question, it's abnormal, okay, high heart rate. In a high heart rate, it'll be the average between the diastolic and systolic pressures. And that's because if you consider at a high heart rate, majority your time now is spent less in diastole, okay? You're probably going to be approaching equal amount of time in systole and diastole in the cardiac cycle as compared to normal. And because now you're spending about half of the time in systole and half of the time in diastole, just because it's going so fast, that's why it's actually going to be more of an average between the two. All right. And again, if you think about a heart going super fast, it's contracting faster, okay, and it's spending less time relaxing. And that's why a high heart rate isn't actually very good. Yeah, it doesn't feel up as nice as it would normally. But this was a hard question, but again, it could come up on the exam. Yeah, next one. So now we're going to talk about venous return and cardiac output. This is super duper duper important. Please listen to this. So I think I did mention this last time, but basically cardiac output is the amount of blood in the total circulation, okay? And that is equal to your stroke volume times your heart rate. Please remember that equation. It's really important. If you remember anything, remember these two equations on these slides. Really important. Usually your cardiac output is about 5 liters a minute. Now, your cardiac output can change, okay? It can go higher, and the best example of that is during exercise because you have increased demand on your tissues and organs, so you need to be pumping out more blood into the circulation. However, if we go lower cardiac output, that is a sign of heart failure, okay, which is not good. Venous return is kind of the opposite. So cardiac output is the blood leaving the heart. Venous return is the total amount of blood coming back to the heart. Now, I talked about Frank Starling last time. When they say Frank Starling, all you're thinking about is cardiac output equals venous return. So you can imagine the heart really wants to pump out all of the blood that it's received. If it's not doing that, it means it's not pumping efficiently and it's having blood left over in the heart that's not being pumped out. Okay, that's if it's out of whack. So it's really important, cardiac output equals venous return. I would say it's highly likely you will be given, in this scenario, you'll be given the stroke volume and heart rate of a patient, and you'll have to work out cardiac output, and they'll ask what is the venous return. That's generally how it goes. So super important. Next slide. So we'll talk about venous return. So venous return has its own equation as well. It's a bit of a fancy equation. Don't worry too much about it. It's not as important as cardiac output equals venous return, but it does have its own. So you can see venous return equals PMS minus PRA on RVR. So all these little acronyms mean PMS is mean systemic pressure, all right? PRA is the pressure in the right atrium, which is almost always 0, all right? So you can kind of ignore the pressure in the right atrium. And RVR is resistance to venous return, which is also not that important because the veins actually have a very low resistance. So it doesn't really matter, to be honest. So since our right atrium pressure is 0, our resistance to venous return, there's very low resistance in the veins, so it doesn't really matter. Your venous return is almost entirely dependent on your mean systemic pressure, all right? So yeah, that's important, which is just the pressure in the circulatory system. And when they use this to calculate There's no blood in motion. It's just static blood. You don't have to know that. Just know that venous return is dependent on mean systemic pressure, which is usually about 7 milligrams of mercury. Very, very unlikely you'll get an exam question on this, but you still do need to know this equation just in case they give you values. And they could very well give you an altered right atrium pressure, for example, for whatever reason. Next, we're going to look at the microcirculation. So when we talk about microcirculation, we're talking about arterioles, venules, capillaries, that type of thing, which is very important. So we're going to go through some definitions. So again, I already talked about arterioles. It is important to know that arterioles are still quite muscular as compared to venules, for example. All right, so remember veins are a lot thinner. Really important to know that. Meta-arterioles are a subtype of arteriole, all right, and they're just the terminal arteriole, the very last arteriole out of all the arterioles. I started saying arterioles so many times. So meta-arterioles are really important because they don't actually have a muscular coat. There's the one arteriole that doesn't. They just have smooth muscle fibers instead, okay? And what is really important is that the meta-arterioles have something called the precapillary sphincter. So if we go back to this diagram, you can see you have your arterioles, okay? You have your venule, and here you basically have your capillaries, all right? So we'll say this is a meta-arteriole. We'll see here it's labeled precapillary sphincter. So a sphincter is just something that constricts a tube, basically. And that is still technically part of your arterioles, not your capillaries or your venule. That's what that is. So a precapillary sphincter is at the transition from meta-arterial to capillary. And this sphincter opens and closes the entrance to the capillary and is responsible for control of blood flow to the tissues. So again, it's hitting on that point that I talked about autoregulation, where your tissues control how much blood they want to them. Okay, they don't want too much coming in. If you have really high blood pressure and you're naturally going to have a lot of blood flow coming in, they don't want that because they still need time to do all the oxygen diffusion or the waste product diffusion. They still need more time, all right? That's why your precapillary sphincters can actually shut off blood flow and just go, oh, just chill. All right, so it just slows it down a little bit. And that is really important to know, and you very well could be asked what is responsible for the control of blood flow to tissues. You have to know it's the precapillary sphincter of the meta-arteriole. Very highly, highly important. Capillaries are basically just where, you can see in the previous diagram, the arterial blood meets the venous blood and it just does its exchange through the tissues. So oxygen is leaving and then coming back, and then carbon dioxide is coming back, sorry. Really important to know, they are porous. Please remember that. And then venules, really only important thing to know is they are slightly larger than arterioles and they're not as high pressure, which should hopefully be making. So now we're going to talk about vasomotion of capillaries. So again, this relates back to our point of autoregulation. It just keeps coming up all the time. So again, it's just hitting the point, blood flow to the tissues is not continuous. Because it's controlled by the precapillary sphincters. And this is called vasomotion specifically when we're talking about these precapillary sphincters. And basically the biggest, basically why your precapillary sphincters decide to close or open is dependent on oxygen. Okay, so if your tissue is in distress and it's needing more oxygen, for example, when you're running a marathon, your muscles need more oxygen, your sphincters will open more, allowing more blood to flow in. There is an interesting point I might just add in to break up the monotony. There is something called a reperfusion injury, which I do think, well, we got lectured about this a little bit last year. But a reperfusion injury, sometimes called a reoxygenation injury, is basically where there's tissue damage caused when blood supply actually returns to the tissue after a period of ischemia. So remember, ischemia is just a lack of oxygen. And this absence of oxygen for a period of time in the tissue actually creates a lot of auxins that are then further activated by oxygen. So this is why in some conditions, this is not really that important to know, this is just a fun fact. This is why that in some conditions, you should not give oxygen too quickly back into tissues because that can actually cause your patient to die if they have oxygen back too quickly. And that's because of the toxins created when there wasn't oxygen, and then you're just worsening that when you are adding oxygen, and that's called oxidative stress. That's not important to know, I thought it was interesting. That's how this sort of relates back to everything. So we're going to talk about the pressure in microcirculation. So if it wasn't enough to know about your macrocirculation, blood pressure, you also have to know the small pressures. These are really, really important to know. I would really suggest, I do think you'll have something on the exam on this. They're really important to know these definitions. If you need to write them out 20 times, please do so. They also will come back in year 2, so it's just easier if you know them now and you've got really good understanding of them. And I think I have a diagram. Yeah, this diagram is really good. I'll come back to it in a second. So you have two main types of microcirculation pressure: hydrostatic pressure and colloid osmotic pressure, which is also called oncotic pressure. So hydrostatic pressure is basically, I like to think about that it's the fluid, okay? The pressure caused by the fluid in the capillary or the tissue, okay? Now, in the capillary, your hydrostatic pressure, the fluid, is the fluid that's going to be pushing through the pores in your capillary into the interstitium, which is into your tissue, okay? Because there's a lot of fluid, it's very high pressure, and it wants to go where there's not as much fluid, which is in your tissue, okay? That's how you think about that. Whereas colloid osmotic or oncotic, I'll just say oncotic, that's easier, is basically the pressure caused by plasma proteins in the blood, all right? So this goes back to semester 1, and basically you have to remember, if you have a high concentration of proteins, say, well, usually you have a high concentration of proteins in your interstitium, okay? High pressure of, high concentration of proteins in your plasma, okay, we'll just think about it like that. Your fluid wants to flow from a high pressure to lower pressure. So if you have a high amount of proteins, you don't have a lot of water, okay? So your water is going to be drawn into the blood. So how I like to think about it is hydrostatic is pushing out, and oncotic is sucking in, all right? That's how you have to kind of think about it. Yeah. And so basically, yeah, just think about osmotic is sucking, and hydrostatic is pushing. And the word colloid in this colloid osmotic pressure, it just refers to protein, and oncotic also refers to protein. That's all that means. So we have hydrostatic and colloid osmotic pressure both in your capillaries and in your tissues. This is why it gets a little bit confusing and why I confuse myself just then too. So hydrostatic capillary pressure, you have to think about, remember, hydrostatic is pushing fluid out, and this is the hydrostatic in your capillaries. Okay, so you're pushing fluid out of your capillaries. All right, so forces fluid outward through the capillary membrane. That is its definition, as represented by PC. So we go to this slide here. We have our capillary, and this is the interstitium. So the pressure, capillary pressure, they generally don't write hydrostatic pressure, but it just means hydrostatic capillary pressure. You can see the arrow, it's pointing out, so your fluid is moving out of there because it's a pushing force. Now, if we look at interstitial fluid hydrostatic pressure, so the pressure in your interstitial, it can really be both. Again, remember interstitial hydrostatic pressure, that's again pushing. So if it's positive, okay, the fluid is going to be moving from the interstitium into the capillary. So you can see here, you have your hydrostatic pressure here, it's positive, okay, so it's moving the water into the capillary. Okay. This pressure can also actually be negative, all right, in certain situations. And in that case, if this pressure is negative, that's a sucking pressure. It's going to be sucking that fluid out. Okay. Then we have capillary plasma colloid osmotic pressure. That is quite a mouthful. I'm just going to say capillary oncotic pressure. Remember, oncotic pressure is just sucking. So we have capillary oncotic pressure you're going to be sucking fluid in. So you can see the fluid is moving in. And then interstitial fluid, colloidosmotic pressure, interstitial oncotic pressure, is going to have that sucking force in the interstitium. So it's going to cause that fluid to move out. Okay. So you can see in both capillary and interstitial pressure, there's both hydrostatic and oncotic, and it's just the net movement of water in and out of the capillary is dependent on whichever force is bigger. So if you can imagine the capillary pressure here, the hydrostatic pressure is really, really huge. It's going to be making water leave the capillary. Okay, that's kind of how it works. But what determines these pressures is called the net filtration pressure. So it's basically the sum of all those microcirculation forces is called the net filtration pressure, and it basically tells you is fluid moving in or out of the capillary. Okay. So if this pressure, the net filtration pressure, is positive, that means the fluid moves from the capillary into the interstitial fluid. If it is negative, okay, the net filtration pressure is negative, it means that fluid moves back into the capillary from the interstitial fluid. That's what is important, and it's given to you by this formula here. And I guess you can see why, because hydrostatic pressure, it cancels out this pressure, and then we're minusing these pressures here as well. So please remember this formula. Very well could get this on the exam as well. And then what else is important is the rate of fluid filtration. So we have our net filtration pressure, all right, and then we want to determine at what rate is blood flowing in and out of these capillaries, and that's given by your capillary filtration coefficient, which just reflects the number and size of the capillary pores in a capillary. Basically, how easily can blood flow in and out? There's a lot of pores, it's going to be flowing really, really easily. There's not so much, it's not going to be flowing as nicely. And you'd be given the KF in an exam. You probably wouldn't get given NFP, you'd have to actually calculate it. They give you these ones, but they give you this to calculate filtration. Important. So now we're going to talk a little bit about the mechanisms of blood flow control. So basically, again, as we've talked, probably the fifth time I'm mentioning this, but you can imagine that if there's an increased demand on, say, your muscles during a marathon, you're going to need an increased tissue blood flow. Okay. Now this also happens. So if you have increased demand of your muscles, you get more blood flow. There's also reduced oxygen availability from the atmosphere, for example, or you're not able to breathe in enough oxygen. Your tissues are also going to increase blood flow. And basically your tissues are trying to grab as much oxygen as possible, trying to suck up the last available oxygen that there is. Okay? That's why when there's reduced oxygen availability, there's more blood flow. And there's two theories as to how it works. It doesn't really matter. You're definitely not going to be asked on this. You just have to know this concept. So you can read that if you are interested in the details. But yeah, we'll talk about reactive hyperemia and active hyperemia. So basically, hyperemia is just talking about an excess of blood in the vessels supplying a specific organ or part of the body. Okay, so if anyone here watches Chubby Emu, that's a YouTube video YouTuber who's really, he's a medical YouTuber. He has some really interesting videos. Highly recommend checking him out. But he always does hyper equals increase in emia, meaning presence in blood. Yeah, if you guys watch that, you know that. Yeah, it's really fun. Basically, so you have too much blood around, okay? And you can imagine this reactive hyperemia just means that there's a lot of blood going back to the tissue after it's been blocked, okay? So, for example, maybe you had a artery, you had it blocked off by a clot, and that's been removed. Your blood needs to go back and resupply that tissue. Okay, so blood flow to the tissue increases about 4 to 7 times after the blockage has been removed. Active hyperemia is just the idea when tissue is highly active, you need more blood flow. Okay, and that's due to vasodilation. So vasodilation is relaxing of the blood vessel. Vasoconstriction is constriction of the blood vessel. That's not, this slide isn't that important, it's just the concept is important. Again, autoregulation makes a comeback. So again, if there's a rapid increase in arterial pressure, there is going to be a bit of an increase in blood flow, but your body counteracts that, okay? Again, by those precapillary sphincters, but there's also some other mechanisms that it does because it really doesn't want too much blood flow going anywhere. So there's two theories. So either the increase in blood flow washes away vasodilators. So vasodilators are little substances produced that increase the size of the blood vessel, and the blood flow literally just pushes them out of the way and therefore constricting the vessel, not letting as much blood flow through. Or there's the myogenic theory, which is the high pressure stretching the vessel causes a reactive vasoconstriction that reduces blood flow. Again, not important to know, but just do know that autoregulation is an important thing. You might be asked, I think you will be asked a question about autoregulation. Probably won't be asked about metabolic myogenic theory. This is just trying to give some background as to why autoregulation is a thing. Compliance. So again, compliance, I think we talked about this a little bit already, but compliance is similar to the concept of distensibility. However, it's really dependent on volume, okay? So again, with the balloon example, that displays distensibility, but it doesn't fully display compliance very well. So compliance is the total quantity of blood that can be stored in the given portion of the circulation for each milligram of mercury pressure rise. So how we'll think about this, arterioles have quite thin walls compared to arteries, and thus arterioles are hypothetically more distensible because they're easier to stretch than the arteries. I'm talking about arterioles versus arteries. But arteries are actually much more compliant than arterioles, and that's because they have a greater volume than the thinner walled arterioles. Okay? This is why it doesn't matter how distensible the actual material is, whether it's a paper balloon or an elastic balloon, it depends on how much volume they can accommodate. So we measure compliance as a change in volume over a change in pressure. So if we have a low compliance, that means the arteries are really stiff, okay? The pressure increases a lot over a small change in volume, okay? Really, they're not compliant, they're not able to accommodate the same amount of volume. Whereas if they're highly compliant, okay, the pressure increases little per change in volume. And this is basically your veins, all right, because they're able to accommodate a large volume of blood. Remember, they have the largest amount of blood in the body, but they don't change pressure that much, even though they have a lot of blood. So this diagram is a pretty good diagram here, and it just illustrates compliance. So you can see on the x-axis, we have volume and we have pressure on the y-axis. So you can see a low compliance. See, if we're increasing volume, all right, we're increasing quite a bit of pressure, okay? Whereas if we have something of high compliance, for the same amount of volume increase, there's not as much of a pressure difference, okay, as compared to this one, all right? So that's why we say it's more highly compliant. That's the main thing you have to know. Again, just memorize, if you're getting confused by this, just memorize the formula and you'll be good to go. Now you'll hear Chris Wright talk about unstressed volume, and I remember I was really confused by this last year. But basically, unstressed volume is represented by V0. It's essentially where we can still increase the volume. Okay, so we're increasing the volume, we're increasing it, but the pressure doesn't change. So we can increase it without making any difference in pressure. Right, that's all that is. You really don't need to know more than that, and I don't think it's very relevant. This is the relevant part. You can ignore the unstressed volume. Yeah, that's pretty much this slide. We'll talk about the lymphatic system. This is important. So the lymphatic system is basically returning your fluid from the tissues back into the veins. Okay, you can imagine if we didn't remove excess fluid from your tissues, we would end up with a lot of extra fluid in your tissues, and that would cause a lot of swelling. And that is actually called lymphedema. Right? So if you have a non-functional lymphatic system, you have excess amount of lymph in your tissues, okay? And this really occurs when there's mechanical failure of the lymph for whatever reason. and the demand on the lymphatic drainage exceeds the capacity of the lymphatic circulation. So maybe you're producing too much lymph. This is important. This is quite an interesting condition. You might have heard of elephantitis. I think there was even a movie called The Elephant Man, I'm not sure. But elephantitis is actually lymphedema. If you've ever looked at images, there are people with really massive swellings on their bodies. It's quite incredible to look at. But that swelling, those really massive swellings, they're because of lymphedema. Because I recommend everyone to maybe, if you have the stomach for it, to actually have a look at lymphedema. It is quite impressive, and it'll really make sense that lymph is really important in your circulation, bringing back all that lymph into your veins. So lymphangitis, it's just inflammation of the lymph vessels, and it's characterized by a red streak. So I recommend everyone have a Google of that. Should have put a photo in. But yeah, that is important, and that could come up in the exam. Lymphangitis, carcinomatosis, I can't speak today, it's fine, but just basically cancer cells in the lymphatic vessels. Don't really have to know much of this, but I would say no difference between lymphedema and lymphangitis, and you should be good to go. Also important to note, this system has valves. That's really important to know. Oh, why is my computer not? Okay, there we go. So the main function of the lymphatic system, as I say, is to carry proteins and large particles away from the tissue and back into the veins. But it's also really important in your immune system, which you probably would have learned already about. And yeah, that's the main part of it. And it is also an accessory route through which blood can flow from the interstitial spaces into the blood. So it has that sort of minor function, but it's not very important. So next bit, we're going to talk about endothelium and its derived relaxing factors. So this is quite important. This ties in, I would say, almost more with pharmacology, because we do take advantage of some of these things to treat certain conditions. So again, when I'm talking about endothelium, it's just the blood vessels, basically the lining, the epithelium of the blood vessels, basically what it is. Important to know that the endothelium of the blood vessels is simple squamous, very important. Again, simple squamous is the type of cell you will find in body tissues that require diffusion. Okay, so you'll find this in your respiratory system, for example, because it requires a lot of movement of oxygen in and out. And that's why you also find it in your blood vessels, because it requires moving of oxygen and nutrients and different things. So endothelium is obviously just a layer of cells in your blood. It actually has a ton of different functions that are super duper important, and if one of these goes wrong, you're in trouble. So it has roles in blood fluidity, so basically how easily the blood flows, whether it's laminar flow. If it's not, remember, if it's not, that's atherosclerosis. Platelet aggregation, so that's involved in blood clotting. Inflammation, angiogenesis, which is the creation of new blood vessels, that kind of goes rogue in cancer, if you can remember, and vascular tone. So basically vasodilation or vasoconstrictions of blood vessels. And this is what we're going to be focusing a little bit more in this presentation. So what I mean by endothelium-derived relaxing factors are basically substances produced by the endothelium, okay, by the endothelial cells, that will vasodilate, make the blood vessel bigger, okay? You absolutely have to know all these vasodilators, and there's some vasoconstrictors. All right, and we'll get to these ones. You have to know all of these. These three slides, please memorize them, very important. Yes, you have to know them. So there's three main endothelial-derived vasodilators: nitric oxide, prostacyclin, and endothelium-derived hyperpolarizing factor. It's really hard to say. So nitric oxide is really important because it is the main anti-inflammatory one here. Okay, so it's just a gas that's made by your cells and it vasodilates. Okay, you might be asked which of these endothelium-derived relaxing factors is an anti-inflammatory, and this one is the main one, nitric oxide. So yeah, that's important. Just memorize the underlined bit and you should be good. Prostacyclin, this is the most potent vasodilator. So you can imagine that is really, really important. Okay, so it's the best one out of all the vasodilators. Definitely learn that. And both nitric oxide, prostacyclins are anticoagulatory, but you don't really need to know that. Endothelium-derived hyperpolarizing factor. This is sort of a last resort. You won't see this in a healthy person. If for whatever reason you're not able to produce nitric oxide or prostacyclin, your endothelial cells will release this, okay? And it's a vasodilator. And also what it does, it can kind of, if you remember your physiology from last time, hyperpolarization just means that the muscle can't, there's a period of time where it can't start a new action potential and it can't contract. So basically it elongates this hyperpolarization phase and it relaxes the blood vessel. So you don't really need to know anything about that, except that it's released only if the other two fail. That is kind of important. Please memorize these. You will very likely be asked, which of the following is not a vasodilator? So do remember them. If you're against stress for time, just remember the names, and prostacyclin is most potent. That's it. Then we have some constricting factors. They're really not that important. You don't need to know any details. You just need to know what they are, and you definitely need to know what they are. So endothelin, angiotensin II, thromboxane, and constrictor prostaglandins are highly important. Definitely know them. Again, you might be asked which of the following is a constricting factor, and if you don't know, you don't know. So please learn these. Very important. But you don't need to know any detail. We'll come back to angiotensin II in a second. Yeah, we'll come back to it. So lastly, we have some humoral vasoconstrictors and vasodilators. So what the difference between a humoral vasoconstrictor and an endothelium-derived constrictor is basically that the previous ones that we talked about were coming from the blood vessel cells themselves, okay? Whereas humoral vasoconstrictors, it just means that it's made elsewhere and it's traveling through the blood, okay? So all of these ones, like noradrenal, is actually made in your adrenal medulla, all right? It's not made by your cells in the endothelium, right? That's all humoral means. Humoral just means blood, okay? Just remember that. So you have some vasoconstrictors, noradrenaline, angiotensin II, and vasopressin. Please remember these, and they come back more in second year when you do renal, which is also quite fun. And vasodilators, bradykinin and histamine. How I remember these is actually makes more sense as a second year when you've learned a little bit more. These ones here, they're actually involved, bradykinin and histamine, just fun knowledge, they're involved in asthma. Okay, and asthma is basically have your lungs are constricting, okay, so your actual bronchi constricting, but your blood vessels are actually dilating, okay, because they want a lot of these inflammatory mediators to come in and keep, I guess, going through the asthma attack. So that's why bradykinin and histamine vasodilate. That's I think the best way of thinking about it. Vasoconstrictors, noradrenaline, this is really involved in your sympathetic nervous system. So you kind of think about, you know, your blood pressure might go up with the sympathetic nervous system. That's how I remember noradrenaline. Angiotensin II is really, really important in high blood pressure. So again, it's going to be vasoconstricting. Vasopressin, I won't talk about that. Yeah, I don't want to overwhelm anyone. But you'll come back to this next year anyway. Just recognize which are vasoconstrictors and which are vasodilators. So hopefully asthma response can kind of help you narrow down bradykinin and histamine and vasodilators. Next, I'm just going to talk, we're almost finished, I promise. We're going to talk about the nervous regulation of the circulation. So we've already talked about the heart effects last time. So I'll just put them down here. And now we're just going to touch on the circulation effects. So unlike the heart, so remember, you should remember, the heart has vagal tone, okay? Circulation, however, has sympathetic tone. It's starting to be like that, it's fun. So basically, the degree to which your blood vessels are constricted or dilated depends how much sympathetic activity you have. Your parasympathetic activity pretty much doesn't do anything, honestly. The only effect it has on the circulation is indirectly through the heart. So for example, you might have a really high blood pressure if your heart rate is going 150. That's because your parasympathetics aren't really doing anything to your heart. That's how it's regulated, but parasympathetics have no effect on the circulation, really. You should know that all blood vessels are innervated by the sympathetic nervous system except for the capillaries, which kind of makes sense. And yeah, honestly, you don't really need to know anything beyond that. You can read through the rest of the slide, but it's not that important. Blood pressure. Okay, so blood pressure, I think last year it was a bit overwhelming and I don't really know what's going on. I promise it makes more sense when you do renal in second year. I promise it makes so much sense. So you're just going to have to bear with me. So you can see here we have this kind of overwhelming looking picture. All you have to know for this year, okay, is baroreceptors, so the black line, okay, and your renal blood volume pressure control. And this is why I say renal, it makes more sense in renal, because most of your blood pressure is actually controlled by your kidneys, okay. That's why your red is actually so big, all right, and it has an infinity sign because it controls it infinitely, okay. There's no limit to how much your kidneys can change your blood pressure. It can just keep going higher and higher if you want, if the kidneys decide to. Aldosterone here as well is also involved in kidneys. So again, it will make much more sense next year when you actually cover kidneys. So you should know from this that your kidneys are involved in long-term blood pressure control, and they have something called infinite gain, which I'll talk a bit more. But short-term, seconds to minutes, okay, or not really hours, but seconds to minutes, your baroreceptors are in control of your blood pressure. Right, that's all. You can ignore absolutely everything else in this for now. All right, so baroreceptors, they're again short-term blood pressure control. Absolutely have to know that. So baroreceptors are basically these stretch receptors. They're located in your carotid sinus and your aortic arch. So you can see you have your carotid sinus receptors and your aortic arch receptors. These receptors are innervated by the glossopharyngeal nerve and the vagus nerve. I doubt you have to know that this year. You come back to that in head and neck in year 2 again. Yeah, you don't really have to know that. You just know carotid sinus and aortic arch, but it's mainly the carotid sinus which does the bulk of the work. Right, that is really important to know. Basically what happens is that these stretch receptors, they will detect if there's a sudden drop in blood pressure, all right? Or if there's a sudden rise in blood pressure, okay? It's very sensitive. And what they do is they will then send impulses to the nucleus tractus solitarius in the medulla, which will then regulate the autonomics of the heart and blood vessels. So it will probably change, it could change the parasympathetic input to the heart or the sympathetic input to the blood vessels. Because remember, blood vessels sympathetic, heart parasympathetic. I doubt you'd be asked through WASH where we travel to. This is a little bit too complex, but if you're keen, you can learn nucleus tractus solitarius as well. So basically your baroreceptors are the reason that when you stand up, for example, you don't just pass out from the pressure change in your body, okay? Because your baroreceptors will sense that change and they will send a response to your medulla, which is basically your brainstem, and that will regulate your autonomic nervous system. So if your blood pressure rises really sharply, this stretches the baroreceptors because there's more pressure, and it causes them to fire more often, okay? And if there's a fall in blood pressure, they fire less. So that's how your body knows what is happening acutely to your blood pressure. So yeah, this is reflexes are triggered during hypertension. Hypertension is low blood pressure after standing, or a mild hemorrhage. I'm sure, I don't know if anyone else has had this experience, but sometimes you stand up really quickly. Sometimes you start having a bit like a vision problem. I hope I'm not the only one. But yeah, basically that's that sudden drop in blood pressure, and your sinuses are just taking a little bit of time to actually start changing the blood pressure there. And they're really important in mild hemorrhage because if you're losing blood pressure, if you're losing blood, hemorrhage is losing blood, you don't want to have a high blood pressure pumping out more blood. And that's good because you don't want to lose blood, but it's actually really bad long term. That's called shock. And that's really not good. When you don't have enough blood going through your body, it's also not good. Yeah, then we have long-term blood pressure control, which is the kidneys, and that's called the renin-angiotensin-aldosterone system, RAS for short. Please do not freak out about this. You'll 100% come back to this next year, and it'll make so much more sense. If you are stuck, just look at this diagram. This diagram sums it up pretty well. You don't even have to know the bottom bit that much. I'd only focus for year 1. You'd only have to know vascular smooth muscle that will cause hypertension. You don't have to know this central bit. But this makes more sense to me as a second year as a full picture. Anyway, so this is important in long-term pressure. So they might ask you, a patient has had high blood pressure for 3 months, what system is involved in keeping that blood pressure? You have to say RAS. So it has 3 main components: renin, aldosterone, and angiotensin, as you can probably guess by the name. Renin is made in your kidneys, okay, and it stimulates a conversion of something called angiotensinogen to angiotensin 1. Okay, and this is made by your liver. Okay, bear with me for a second. After angiotensin 1, it's converted to angiotensin 2 by something called an ACE. Okay, angiotensin converting enzyme, which is made mainly in your lungs and also a little bit in your kidneys. Okay, so it converts that. Now, angiotensin 2 is sort of the bad guy in hypertension. It goes and it constricts your blood vessels, causing hypertension, so increased blood pressure. It also does some other things, so it enhances your sympathetic nervous system. So again, that's the effect on your circulation will have hypertension. Also increases your sodium and water retention. So if you can imagine, if you have more sodium and water in your blood, okay, there's going to be more pressure in your circulation. And that happens through something called aldosterone, but you don't need to know that for this year, just if you're interested. And yeah, that's the main thing that happens with this blood pressure. That's really all you have to know. You do definitely have to know this diagram. Please memorize it apart from all these unnecessary extra bits there. So now we're going to talk about infinite gain. This isn't the most high yield, but I remember, I think it was Chris Wright talking about it last year, and I was really confused. I don't know what it meant, but I figured it out because of this. So basically your kidneys, so going back to that diagram here, you see your kidneys long term, and they have an infinity sign at the top. It means that they basically have infinite ability to change your blood pressure. Okay. So how it does that is the infinite gain principle. All right, and it's the balance between your renal output of water and salt. Okay, so the amount of salty water you're excreting versus the amount of salty water you're intaking, okay, drinking. Obviously you don't drink salt water, but you get what I mean, water and salt. So basically for a given intake of salt in a given functional state of the kidneys, there is only one single arterial pressure that will provide a balance between intake and output of salt. And because of this, this is the arterial pressure. Now that sounds really overwhelming, but I promise you just have to really, I recommend everyone sit down with this slide and have a look at this diagram because it really makes sense. So basically, at a given intake of salt and water, so it's this black horizontal line here, all right, there's only one pressure which will balance the intake and output of salt. Okay, so renal output of salt here, and it's this point here. So arterial pressure is 100 in this person. All right. So in other words, the body selects a blood pressure normally in a healthy person 120 on 80, and it really wants to keep it there. Okay, because your salt and water input is equaling your output at that pressure. Now, to maintain this pressure consistently over time, salt and water output must meet input. So if you have, say, more output of salt water than you're taking in, you'll have a decreased blood pressure. Okay, you have to think about that. You're having more, you're excreting more salt and water than you're intaking, you're going to have a decrease in blood pressure. So you can see by that curve, decreased intake, your blood pressure will decrease. And infinite gain just refers to the fact that it can change the body's balance of salt or water, input and output, to make the blood pressure stay consistent. So if you need more water to increase blood pressure, it will decrease output and increase input of water. It's quite a hard thing to understand. You just have to go back and really look through this slide. Trust me, it'll make more sense. Yeah, and then this one just talks about how using this system, blood pressure can be increased. So the blue and red lines basically represent your kidney's ability to balance salt and water. Okay, sorry. Black straight line is your intake of salt and water, which is again like eating and drinking. So in the figure A, your intake of salt and water has stayed the same. So you can see the black line has stayed the same, intake's the same, you haven't changed your diet. But your kidneys have for some reason decided to retain more salt and water. Okay, then you're not peeing as much basically. Okay, so they've gone from being normal to having a bigger retention of water and salt, therefore your pressure increases. Okay, so that's why your arterial pressure is now at 150. In figure B, you can see that your kidney, the blue line, the kidney function has stayed the same, but you started being a bit naughty and eating a lot of chips and drinking a bottled water. Okay, and your blood pressure, because that's now represented by your red line, that's your intake of salt and water, has increased. Your blood pressure increases to 150. Okay, and this is what's happening in hypertension, right? Because usually your body can accommodate pretty well. Your kidneys should be working pretty well, okay, in a healthy person. That's why figure A should not be happening in a healthy person. If it is happening, it's a problem with their kidneys. And with B, really the degree of salt and water intake, even if you binge on 5 packets of chips, is probably not going to make too much of a difference in a healthy person. Okay. Having said that, there are people that will overdose on drinking things like soy sauce, which is basically all salt. And unfortunately this happens and they have really super high blood pressure. Again, look at Chubby Emu if you're interested in that. He had a cool video. This entire presentation is me just giving him a shout out. Yeah, just have a look. Again, this is not super high yield, but this is kind of important. I think Chris Wright really likes to label this point, so this just hopefully gives an explanation. Okay, we made it through the end of cardiac quiz. Sorry, that's a bit of time. We're just very quickly going to look at blood vessel histology. I think the reason I decided to put this in was because I remember last year in my exam, we had something on blood vessel histology and I was not prepared for that. So this is so you guys don't make the same mistake as me and ignore histology. I'm not the biggest fan of histology and I'm not happy about it. But basically for this, you need to know the difference between what an artery looks like and what a vein looks like. So you can see arteries have a very thick wall as compared to the veins. Okay, that's number one, first and most important thing. You have to know the difference between. If you know that, you're 50% of the way there. And then it is important to know the difference between an elastic artery and a muscular artery. Yeah, that's pretty much all you have to know for blood vessel histology. And you do need to know about tunica intima, media, and adventitia. That's just the layers of blood vessel. Intima is like intimate, right? So it's very close to the center. Media, and for middle. Adventitia, every time you see adventitia or serosa, that just means like the outer layer. That's all that is. Yeah, that's pretty much all I have for vein histology. I'm not the biggest fan, and it's probably all you need to know. So yeah, that is, oh yes, and this is the summary of important equations. If you are stressed, just memorize this and you should be good to go. Just hopefully the rest of the slides give a bit more explanation as to all of this, because it is a little bit like, oh, what does any of this mean? So hopefully you have some vague idea now. Yep, so that's me done. We're not presenting cardiac farm today, but we'll be doing clinical skills. I'll just stop sharing. If you have any questions, please feel free to ask me. I know cardiac quiz can be really hard, but yeah, good luck.
We're just going to go through cardiac clin skills really quickly. So first up, I believe you guys have gone through or will have gone through the cardiac systems review and the exam, so those are really important. So as with every single systems review, there's just going to be a bunch of questions that you'll have to ask and go through. It's really important that you understand what they are and also try to figure out how to ask them in lay terms to a patient, because some of them, like ankle edema or intermittent claudication, if you ask it to a patient, they're going to have no idea what you're talking about. Also, systems review comes with a really helpful mnemonic that Nadita, I think, talks about, because I remember her bragging about it to our ICL last year, paid COPS fatigue, which is just all the first letters of the questions that you need to do. So for the next few slides, there are just a couple of ways in which you can phrase these questions, because pretty much all of them, other than maybe fatigue, you have to try to figure out ways in which you can bypass the fact that they don't really make sense to a normal person, or a normal person's not going to have heard it. And it's also a really good idea if a patient says yes to a question to have a couple of follow-ups. So for example, for palpitations, you can ask what they were doing at the time, or for intermittent claudication, you can ask how far they can actually walk between the pain. I know there's not a question for edema on this slide, but if you really want to ask a question, maybe you can ask like when they notice the swelling, so get a time frame for it. So note that for ankle edema, so it's really important that it usually occurs in right-sided heart failure. And it's also important to remember that edema is gravitational. So usually it's around your ankle if you're erect, but if a patient is bedridden or supine for a very long time, your edema is going to pull at the back. So that's why in the cardio exam, you're going to be feeling for sacral edema, so around the back as well. So we'll just skip through these slides quite quickly, and you can have a look through them in your own time. So we'll go on to history indications. So there are a couple of common CVS risk factors. So some of them are things like a past history of a CVS disease. There are some drugs like estrogen replacement therapies or even recreational drugs such as cocaine or amphetamines. They can actually increase the risk of an MI in young people. And so other things that aren't on the slide are things like male sex. So males have a higher risk of coronary artery disease and just heart disease in general, hypercholesterolemia or hypertension. So going into detail about the types of chest pain, I've just highlighted the one that I think is really classic and really important, but there are other ones here as well. So you've got the one that is, so the cardiac pain that's usually going to radiate towards the jaw or the left arm. And this is really classic, especially for heart attacks. And it's just the main takeaway from the slide, but there's also different types of pain that you can come, and different types of chest pain, and the way that they are will actually just determine where or what origin they're coming from as well. So here are some of the coronary artery disease risk factors. So family history is always a really big indication, but there are some other specific symptoms such as smoking, hypertension, or etc. And they're all really similar to the CVS pathology. All right, so the cardiac exam. So as a disclaimer, your cardiac exam is quite long. Since you guys aren't being formally assessed in the context of clin skills, I haven't put an explanation in for every single step, but because whatever I write up is just going to be a rehashed version of the table that you'll get in like your clin skills booklet. So I've got a link up to Geeky Medics that I've had a look through, and if you guys want to reference to the visuals, that's always really helpful. But I think that it's really important that you don't write the exam off. So there are really important aspects that can easily come up in your exams in the form of MCQs. So for example, learn the order of auscultation. So for example, your mitral area, you've got your bell first and then the diaphragm of your steth. Learn the special maneuvers and where, like what costal cartilages and just where they are in the chest. Learn where your apex beat is, learn the cervix landmarks, and learn about the JVP, where it's found and on what side. So we'll go specifically into the JVP a bit later, because I know that that's something that a lot of people find quite just confusing. So we're going to cover some of the signs that we went through and what they can actually indicate. So this is another thing that's really important to cover, because it's basically related to all your pathology. So we'll be going through cardiac pathologies next week, and you'll find that a lot of these signs are going to be repeated in the different types of just signs like coronary artery disease, heart failure that we're going to be seeing when we get actual patient interaction. So first of all, we've got clubbing. So I've shown you what it looks like on the slide, but classically in an exam situation, you get your patients to make like a diamond shape with your fingers like that. And it's associated with congenital heart disease and infective endocarditis. Splinter hemorrhages. So splinter hemorrhages are just like a thin kind of linear collection of blood that's underneath the nail plate. It's usually due to the rupture of nail bed capillaries. So classically, in terms of the pathology, infective endocarditis again, but it can actually be due to trauma as well. So make sure that you get an indication of like what their actual work and occupation is. We've then got Osler's nodes and Janeway lesions. These are once again like indicative of your infective endocarditis. We've got tendon xanthomata. So this is just lipid deposits. So the picture on the right is just a knee, but it can also be in your hand. So you'll have to talk about the fact that it's in your hands as well when you do your cardio exam. It's indicative of hyperlipidemia, which is a risk factor for cardiovascular disease. You've then got bradycardia and tachycardia. So they're abnormal heartbeats. The first one is a slow rate, so that's bradycardia. And the second one, tachycardia, is a fast heart rate. So note that the rate and like the rhythm is different. So they can also be like a regular or irregular rhythm. So irregular heart rates are arrhythmias. And so that's basically when your heart rate is uneven. We'll go into that into further detail next week, but also when you go into ECGs, when you can actually see the heart rate on like a tangible diagram, it's more apparent like what exactly it is. All right, so we've also got radial and femoral pulse. So your radial pulse is the one that you typically think of. So it's just at the groove of your forearm and your distal wrist. Your femoral pulse is in the inner thigh at the mid-inguinal point. So your mid-inguinal point is that point halfway between the pubic symphysis and the anterior superior iliac spine. All right. You've got cyanosis then. So cyanosis is just the blue discoloration of skin, and it's usually due to the presence of deoxygenated hemoglobin. So you're not getting enough oxygen to your hemoglobin molecule, so you get either peripheral or central cyanosis. So peripheral cyanosis is mainly seen in the limbs. Central cyanosis is more of a bit of like more worrying, and it's when it's seen on your tongue and your lips. So jaundice and xanthelasmata. And jaundice is just the yellowing of your sclera. Xanthelasmata is this part in part B, and it's just these cholesterol deposits that are around the eyes, and they'll be really apparent. Note that xanthelasmata is quite rare, but jaundice is associated with a whole range of things. So you can, so it'll probably be something that you'll see. I can't say this one, arcus senilis, I guess. And it's literally a grey circle around your outer pupil. Again, it's super rare as well. So mitral facies is the next one up. It's just a reddish tinge over your cheeks. And again, it'll be quite apparent when you see it in a patient, because usually it's quite red, and sometimes it can have like a tinge of blue as well. All right, so next we have a high arched palate. So a high arched palate is synonymous with Marfan's syndrome. So Marfan's is just an autosomal dominant disorder that is going to affect your connective tissue, and it can result in a range of cardiac pathologies like mitral valve prolapse, for example, as well as like aortic regurgitation and mitral regurgitation. All right, so I've talked a little bit about left-sided and right-sided heart failure. So I know that this is something that is emphasized in your clinical institute. So I've just got a little bit of the differences in terms of clinical signs and symptoms that you'll see. We'll go into the pathophys of these both next week. So there we go. All right, so from physiology, you'll know that you've got two heart sounds, and sometimes these can become abnormal. So there are a couple of reasons for your abnormally large S1, a loud or soft S1 or S2 heart sound. And so there we go. So they've got this two over here, and you'll just be listening to them with your steth. And then we've got the same thing with heart murmurs. So heart murmurs are going to be caused by turbulent blood flow. We know that we have systolic, diastolic phases, and we also have a continuous. If you have a continuous heart murmur, then we have, that's patent ductus arteriosus. So that's in embryology, was covered with anatomy. All right. You can sometimes hear a pericardial friction rub on auscultation, and this is mainly indicative of infection inside the pericarditis, or just the pericardium, which is just your sac around the heart. All right, so pitting edema was what we've talked about before in the history taking, but the pitting just means that you can press into it, into like the edema or where the edema is, and there'll actually be an imprint of your finger that remains there for a few seconds after you actually remove the force of your finger. And this occurs with right-sided heart failure. So I've just dedicated the next couple of slides to the JVP, because I know that it's something that people often struggle with, and finding it on a patient is a nightmare. So the JVP is a measure of central venous pressure. So more specifically, it's an estimate of the pressure inside the right atrium. So here's how you find the JVP. So you should note that, so your patient is basically going to be supine with their torso up at a 45-degree angle. You'll ask them to turn their head towards the left-hand side, and you're mainly looking for the flickering. So note that it's not a palpitation, it's not something that you can feel, it's mainly just a flickering of your internal jugular vein. And you're going to be measuring the vertical distance between the upper limit of this flickering internal jugular vein and the sternal angle. So the sternal angle is just the top. And so you need like a ruler and whatever. And basically, if you've got a distance of more than 4, then you say that it's an elevated JVP. Okay, so in Clin Skills, you'll go through this diagram in a bit more detail. But you've got a couple of waves that are associated with your JVP. So you've got like an A wave, C wave over here, X descent, V wave, Y descent, and your A wave starts once again. So here are what each of the waves and what they represent and what's actually causing them in the cardiac cycle. So A wave is corresponding with your first heart sound. Your C wave is due to the carotid pulsation. Your X wave is quite late in systole and it's caused by atrial relaxation. Your V wave is due to atrial filling, and your Y wave is due to your tricuspid valve opening. So in terms of the difference between your JVP and your arterial pulse, so there are some differences that you can see in real life and they're on the slide. So the most important one is the fact that your JVP is visible but not palpable. So you can't, when you touch it and when you see the flickering, you're not going to actually feel anything, which is different to sometimes you can palpate like a pulse. For example, your radial pulse, you can feel it at the junction of your wrist. All right. So we talked about the fact that there are some abnormalities. So for example, elevated JVP is probably the one that you'll see most of the time. So it's cause for concern because it can indicate a number of things, such as right-sided heart failure, fluid overload, or cardiac tamponade. But that's not the only thing. So that's the most common abnormality that you'll be asked about. But you can also have like an absent wave. So usually it's an absent A wave. Or a large A wave, and you can also have an absent JVP in total as well. And that's usually just going to be due to dehydration and hemorrhage. All right, so that's pretty much it for cardiac Clin Skills. I zoomed through it because I know that you guys don't have a lot of Clin Skills knowledge, and at the moment it's quite hard to like understand what's happening, but it's really important that you go through just the theory of everything that I went through, because you will find some MCQ exam questions on it, but hopefully it made it a little bit more clearer.